Thank you, ma'am, for the informative talk. Polycystic ovarian syndrome is a condition that affects a woman's hormone level. Women produces higher than normal level of male hormone, causing irregular menstrual period, abnormal hair growth, infertility, weight gain, etc. Causes of polycystic ovarian syndrome is not well understood, but may involve combination of genetic and environmental factor. Our next topic is lean versus obese PCOS. Does the infertility management and outcome differs? For this, I invite our next speaker, Dr. Leena Wadhva, ma'am. Please, ma'am.
Welcome, Dr. Leena. She's a professor of OBG in charge reproductive medicine and surgery IVF at Basidapur, New Delhi. She has fellowship in Ethicon fellowship in the field of endoscopy. Foxy, Dr. Vasant Ben Shah overseas scholarship. She has the training of endoscopy from Germany, training of embryology from Chennai. She spoke up on Kamini Rao Foxy oration in AICOG 2012. She has, to her creditations, 50 paper publications in international and national journals on current concepts of contraceptive and world's health. Her field of interest is reproductive medicine and infertility enhancing endoscopy. She is the joint treasurer of Indian Infertility Society. Welcome, Dr. Leena.
एक बार जोरदार तालियां लीना के लिए। सुबह में कुछ कहानियां और हर्डल्स की बात कर रही थी, तो एक छोटी सी कहानी सुनाती हूँ। परसों डॉक्टर स्नेहा का फोन आया। डॉक्टर स्नेहा सपोज टू बी द स्पीकर ऑफ दिस सेशन कि डॉक्टर मनीषा माय फ्लाइट गॉट कैंसल्ड एंड मैं नहीं आ सकती। लीना यूज्ड टू बी माय फेवरेट जूनियर। तभी मेरे अंदर की सीनियर वाला भाव जागा एंड आई ऑर्डर्ड हर एंड विद इन 36 आवर्स शी इज हियर। A big round of applause for Leena.
Yes, welcome, Dr. Leena. That was very sweet of you.
Thank you, Dr. Manisha, and it's a pleasure to be here with the Ghaziabad Obs and Gynec Society, and I congratulate the whole team for organizing such a wonderful CME. I went through the talks, the speakers. It's well organized, and all the topics are very, very relevant and very good. So I'll be discussing about another important topic. This is lean versus obese PCOS. Does the infertility management and outcome differ? We know that PCOS is the most common and least understood endocrinopathy. And usually what we encounter is obese PCOS in our usual practice, 30 to 80%. And 20 to 30%, they belong to lean phenotypes. So we see various presentations of PCOS. So what is important before going further is something to counsel these patients at a young age when they come to you regarding the pregnancy complications, the quality of life, and increased risk of metabolic syndrome and cancer in these particular group of patients. So I'll be first describing two cases. One is obese PCOS, other one is lean PCOS. So let us see how the outcomes and management are different in these two groups. This patient, she is a case of obese PCOS, 28-year-old, presenting with oligomenorrhea, infertility. She has acne with menses, waxes her upper lip chin weekly. Although her BP is normal, look at her BMI. It is very high. It is 31 kg per meter square. And her waist circumference, that is central obesity, is also high. It is 89 centimeters. She has terminal hair, acanthosis. And there's also a family history of type 2 diabetes. And on workup, her LH levels are high, and OGTT is deranged, and lipid profile is also abnormal. So she fits aptly into the criteria of metabolic syndrome. I'll not go in details, but basically what is important is abdominal obesity, which she has. The glucose is deranged. The lipid profile is deranged in this case. And if we grade her obesity, I mentioned it is BMI is 31. So as per WHO and as per Indian standards also, although with the Indian, I think this pointer, is it working? Okay, I think we go back and forth with this. Can you please tell me how to use the pointer? I don't know this. एक बार बता दो इसको ना. The slides are gone. So basically, we know that she is a case of primary infertility with obesity, BMI is 31, and a case of metabolic syndrome. हाँ बस मेरे को ये use करना है. Okay. Okay. And more of central obesity, which I mentioned, central obesity is a very high risk factor for metabolic syndrome when the waist hip ratio is more than 0.8. And if we talk in terms of the waist circumference, if it is more than 80 centimeter, and in this patient she had 89 centimeter of waist circumference. So this patient is primary infertility with obese PCOS with metabolic syndrome. Let's look at another case. She's a case of lean PCOS, company executive, married for 3 years, trying to conceive. She has oligomenorrhea, often on OC pills. Look at her BMI. It is 16 kg per meter square. Her AMH is raised, 8, LH is high, and she has ultrasound 10 to 15 AFC in each ovary. So let us learn the difference between lean and obese PCOS. In lean, as we have learned, the BMI is normal or low, and in obese, majority have high BMI. In lean PCOS, they may or may not have insulin resistance. It ranges from 6 to 22%, whereas insulin resistance is very, very high in obese PCOS. In lean PCOS, they exhibit typical symptoms, acne, irregular menses, particularly which I'll be mentioning in my next slide also. They are at potential risk of depression, the lean ones. And the obese PCOS, they also present with different kind of manifestations as per the Rotterdam. Till now, what we have learned is our basics, that as per Rotterdam's, we have learned that there are 4 types of phenotypes, and we talk about these 4 phenotypes. That is type A, which is the classical one, which has all the 3 features of androgen axis, ovulatory dysfunction, PCOS morphology. And from our learning that we know, these are the high-risk obese one PCOS, whereas C are the lean one with androgen axis and PCO morphology. But now the change which has come recently, this is the very recent paper published in 2022, which says that comparing lean and obese PCOS in different phenotypes, now the evidence is coming that the body weight is more important than the Rotterdam phenotype in influencing the metabolic status. So let us go through this paper. In this, they found in both phenotype A and C, the lean patients were more in both the groups. And what they did is they categorized obese and lean PCOS in all the 4 phenotypes, and then they compared. And their observation was that obese patients of each phenotype, whether it is A, B, or C, they significantly have higher insulin, higher HOMA-IR and triglycerides, and significantly lower AMH and HDL. So this is very, very important. So they concluded that although Rotterdam phenotypes express the differences between PCOS patients in terms of ovulatory pattern and androgen secretion, they fail to differentiate between obese patients with altered metabolic patterns and lean ones with normal metabolic patterns. So now I'm here behind you to talk about the obese and lean PCOS, because now the time has come to accept this change, and really a new classification of PCOS is required now, which should consider the influence of body weight on the metabolic patterns of PCOS patients. So now coming to the management, when we compare to the obese PCOS, it should be clear whether this should we advise lifestyle modification to the lean PCOS. When you see a lean and thin patient, should you tell her that what about her weight, whether she should go for weight reduction? She's already so lean PCOS. What should be the advice, whether we should test her for metabolic syndrome? What will be the difference when we are comparing lean and obese PCOS? So we have to go step by step. I'll be discussing in detail about the diet, the next is exercise, behavioral approaches, pharmacotherapy, and surgery. But a word about preconception counseling, which is very important, and especially about lean PCOS. As I've already mentioned, emotional disorders, anxiety, depression, they are more common in lean women with PCOS. The reason behind this is a ghrelin hormone that affects the symptoms in lean patients. And another important finding was that beta endorphin level as well as pressure pain threshold were found to be higher in lean PCOS. And this beta endorphins, it increases the LH. So in lean PCOS, we find that LH is more raised. So what are the implications we'll be discussing in next few slides. So preconceptional counseling is to be taken by care by healthcare. You have to identify the risk factor, counsel them. Multivitamin supplementation, especially vitamin D and calcium supplementation is required. And then you have to explain all the about the procedure, side effects, success, costs, and husband's role is also very important. And even when you're carrying out the treatment in PCOS, you have to continue with the counseling regarding lifestyle, regarding diet, when you are doing ovulation induction, the risk associated, multiple pregnancy, OHSS, and if she needs bariatric surgery, then she needs to avoid pregnancy for at least 12 to 18 months. So first talking about the obese PCOS, when we are counseling the patient, we have to tell them, look, you have to reduce your diet. It should be deficient by at least 500 kilocalories, moderate exercise of 30 minutes, decrease stress, cessation of smoking, and decrease alcohol and caffeine consumption. And to all PCOS patients, whether it is obese or lean, you have to tell about the healthy diet, avoid saturated food, processed food, fried food, include more of a high fiber diet, fruits, vegetables, salads, nuts, seeds, oil, etc. Vitamin D and calcium I've already mentioned. So how does this lifestyle help? With lifestyle, there's decrease in central obesity, which further leads to decrease insulin resistance, decrease in androgen, and it restores the normal menstrual and ovulatory function. So these are the different exercise, yoga, you tell to your patient. And with weight loss, definitely it restores ovulation in 23%, increases pregnancy rate, and decreases miscarriage rate. So there are various type of PCOS diet plans, which I'll not go in detail. But the crux I've already mentioned, patient has to be advised low glycemic index diet, Mediterranean diet, DASH diet. So these are the different types of diet advocated in PCOS. And exercise, ADA recommends minimum 150 minutes per week of moderate to vigorous exercise. And minimum 1 hour per day of exercise is recommended. This is another very, very important narrative review in which they have studied lean PCOS over a period of 17 years. And this review just focused on lean PCOS, what are the hormonal changes, what are the management of lean PCOS. And what they have advocated is, although we say that weight loss is the first therapy for obese women with PCOS, what about the non-obese women? We have to tell them to go for resistance exercises. How does these resistance exercises help? It improves hyperandrogenism, reproductive function, and body composition by decreasing visceral fat and increases the lean muscle mass. So we have to talk about the weight maintenance and resistance exercise in lean PCOS. In lean PCOS, this is important because they have an apple-like fat distribution. In ultrasound, it has been documented that lean PCOS, they have more of pre-peritoneal and visceral adiposity. And important is this, lean patients, why they're so lean, they have intrinsic insulin resistance, whereas obese, they have both intrinsic and extrinsic. And in lean PCOS, you find that overall, the total subcutaneous adipose tissue is less. So this typical apple-like fat distribution, and that is the reason you tell them to have more of resistance type of exercises and weight maintenance. The next question which is important, should we screen lean PCOS for metabolic syndrome? Are they at high risk? So the evidence says there is elevated insulin resistance, oxidative stress, plasma homocysteine, as well as changes in lipid profile which have been seen in lean PCOS. There's increased risk of diabetes. So they are also at risk of metabolic syndrome. We should screen both obese and lean PCOS with metabolic syndrome. What is the role of metformin in metabolic syndrome? We know that metformin, if given, it reduces insulin resistance, hyperglycemia, delays diabetes, reduces cardiovascular risk. So these are the RCOG recommendations in which patients you're going to metformin, where the BMI is more than 25 kg, where she's at risk of impaired glucose tolerance. And we know that metformin, we start with a lower dose, 500 milligram, then we increase gradually. And in lean PCOS, the dose of metformin will be lower, maybe 500 milligram BD, whereas in obese, we go up to 850 BD. So metformin can be given as a first-line drug to all women obese and non-obese with PCOS and anovulatory infertility. A word about myo-inositol. Although the evidence, it says it is experimental, but we all know that it is a nutritional supplement. As per the evidence, that it has been suggested that myo-inositol improves metabolic, hormonal and ovulatory function. So it can be used despite limited lower quality evidence. And especially in lean PCOS, it has been found that myo-inositol reduces LH levels as well as high sensitivity CRP and androgens and improves insulin tolerance. And along with the myo-inositol, L-carnitine levels, they are low in lean PCOS, so it can be added on with that. Go in details, but important is obese with BMI more than 25, they have poor outcome of laparoscopic ovarian drilling. Extended letrozole therapy has been tried in PCOS women. Letrozole has been given 2.5 milligram OD for continuously for 10 days. And it says, although I haven't tried, but this protocol is useful. Then step-up chronic protocol, I've already mentioned, you start with 50 or 75 and gradually you increase the dose depending upon the response. Regarding recommendation for starting ART, if a patient is very obese, you have to tell her to reduce her weight. Please don't start treatment until her BMI is less than 35 kg per meter square. That is very important. So to sum up ART management, it is metformin, pre-treatment with OCPs, especially if LH is high. In these patients, we go for GnRH antagonist protocol using low-dose gonadotropin. The trigger used is GnRH agonist, no SCG, and cryopreserve, and go for frozen embryo transfer to reduce the risk of OHSS. And as I've already mentioned, it is the lean one who are hyper responders and at high risk of OHSS. And addition of metformin also helps in reducing OHSS in PCOS. And I'll not go in detail about the obese PCOS, only the drug which is used is Orlistat. And if the details, I'll not go now because of shortage of time. What are the conditions in which you will advise surgery to a obese PCOS if her BMI is more than 37 or with 32 she has other comorbid conditions? The bariatric surgeries, I'll not go in detail, but it is important to tell her not to conceive after 12 to 24 months after bariatric surgery. And after bariatric, there's more of malabsorption syndrome, proteins, folates, multivitamin, all this supplementation is required to the patient. I'll just come to my last slide regarding the outcomes. If we compare obese versus lean PCOS, compared to non-obese PCOS, the obese women with PCOS, they have less retrieved oocytes, increased miscarriage, and lower clinical pregnancy rates. So to sum up, the lean PCOS, they are more prone to depression and psychiatric illness, whereas in obese PCOS, they are more prone for metabolic syndrome, diabetes, cardiovascular disease. In lean PCOS, we advise resistance exercises, weight maintenance, addition of metformin, myo-inositol, carnitine, low glycemic index. In obese PCOS, we advise weight reduction. Metformin, myo-inositol can also be used in them. But in very obese, Orlistat and surgery has to be considered. Vitamin D, calcium supplementation should be given in both. In lean PCOS, she's at high risk of OHSS, more of oocyte retrieval. So one has to be very, very alert and cautious. In obese PCOS, there's less of response, less oocyte retrieval, more of clomiphene resistance. And in lean PCOS, definitely they have a better pregnancy outcome as compared to obese PCOS. Thank you for the patient hearing. Thank you, ma'am.